the Ashford and St Peter's main board meeting, and we're going to kick off with any declarations of interest in the proceedings, please. So anybody who's got anything on the agenda that they wish to declare an interest in. No? Okay, thank you. Apologies, please, Les.
Apologies from Louise Mackenzie and Paris Zachariah.
Okay, thank you. And just to note that this is will be Yvonne's last meeting with us, and just to formally put on record my thanks to Yvonne for all the time and effort that she's put in over the last year. You've been a real support to us, Yvonne, and I'm hoping you've learned something too through this process. But a big vote of thanks from everybody on the board for all your efforts with us.
Thank you, Andy. Can I say a few words in response?
Yes, you can. Yes.
Okay, I'll try not to sound like a broken record because some of you attended the governor's meeting, but I found this scheme very, very helpful, very insightful, and it's done a lot for me, and I'll tell you why. So I came across this scheme early last year. I really just stumbled across it, but it was an opportune time for me because I was at a stage in my business where I felt I was plateauing. The business had run for 10 years, the current business I'm doing, and I wanted to raise my leadership lid. I wanted to be sharpened because I sharpen everybody else. So I thought this was a great opportunity, and also to make a difference in the NHS. As a social care provider, my experiences with the NHS, the particular trust I work with, have been quite challenging. So I really thought, you know, it was time to make that difference and possibly show them how things are done. So 3 things that really struck me since I've worked with Ashford and St Peter's are its values. They resonated with me immediately. And that was a key thing for me because everything I do in my executive role is mainly values driven. So to see like for like was very encouraging. And working as a NED as well was also a new thing for me. I'd never done that before. I was hearing a lot about assurance, approval, assurance, approval, assurance, approval. It seemed to be a common theme, but gradually I managed to get my head around it, as well as all the jargons that the NHS has. I think the first board meeting, Simon was sitting next to me and he must have probably seen how flabbergasted I looked and confused. And he kindly said, look, there's an NHS jargon buster app. And I thought, great. So thanks, Simon, for doing that. That was really helpful. And of course, Andy as well said to me, you really need to do a year on this. NHSI had recommended 6 months and I thought 6 months. But when I saw the enormity of the landscape of the NHS, I realized you really do need a year. And, you know, I'm 1 year on and I'm just beginning to pick up things and contribute. So thank you, Andy, for recommending that. Finally, it's just to say that I've been able to look at the NHS through a different lens, a more positive one, a more objective one, which is great for me because as a social care provider, I can apply myself, or let me say I have been applying myself differently because I understand what the NHS goes through. But also it's not every NHS trust that's the same. And I have to say Ashford and St Peter's is very unique. You have a great team, you have a great board. And I've always said this from the onset. I remember Suzanne said, if there's anything you think we need to improve, do say so, because a fresh pair of eyes is always helpful. But I've never really had anything to say. I mean, everything has been great. And it's been really good working with you, especially for me. I left the corporate sector in my late 20s, about 17 years ago at a young age. So it's nice to be back in the fold, so to speak, and to be sharpened. And I'd like to say thank you, Marcine, for mentoring me and getting your finger out every time and saying, no, you must, you must, you must. So thank you very much. And it's been great working with you all. And I hope at some point I'll be able to work with you all again. And also another thing I remembered regarding the scheme, which is the first time I understand the trust has done this, which I thought was is good. I'm hoping that the trust will be able to bring in more diversity at board level, whether it's ethnicity, it's gender, it's experience, it's age. I think I'm the youngest person amongst all the Neds. So it's nice to have, you know, mature minds, or let me say wiser people to work with. But yeah, I've enjoyed it, and I hope it's given the trust some insight as to where they may go in the future. So thank you, everybody.
Thank you, Yvonne. That's very, very helpful. Very kind words for us, and we certainly will be pursuing, you know, that scheme, because I thought it was a good scheme. When I ran across it, I thought it was a really good scheme to bring people through on and give them real board experience. So and then equip them for, you know, going for board roles.
Yeah.
So that's absolutely great. Thank you.
Oh, I just remembered, as you mentioned border roles, Andy, I think some people have asked me, so I'll just tell everybody. I've been asked to join an advisory board of Nightingale Hammerson. For those of you who don't know, it's a care group in London. Whenever they set this up, I'm not sure exactly, but that's where I will be going at some point this year as a result of it. So thank you.
Congratulations, Yvonne.
Thank you. Thank you.
Yes, that's David. Yeah.
Oh, David. Thanks, David.
Okay, so thank you for that. We're going to move on to the sort of formal part of the meeting now, and we're going to look at the minutes for May. So has anybody got any comments, matters of accuracy, etc., on the minutes for May? Okay, I'm going to take those as agreed then. I'm trying not to smile at the meeting chat, which will also be recorded, remember. So I muted there so my grandfather clock didn't disturb people. Okay, so we'll take those minutes as agreed. Well done, Liz. And we'll move on to actions arising. And I don't think there are any particular ones there. I think they're all closed off. Is that right, Liz?
Yes, sorry, Andy, yes.
Okay, thank you.
For future meetings.
Yeah, so all there for future meetings, absolutely. So I've got no further actions on today. Okay, so we'll then move on to reports, where we've got my report and David's report. I will take my report as read, but I'm just going to reiterate something I said last time. Actually, I have been deeply moved by the absolute work rate and teamwork of colleagues across the trust. I'm in a privileged position as a non-executive chairman that I do still come in. And I think the level of teamwork, the level of leadership, and the level of application is really impressive. And I'd just like to put on record for the executive colleagues on the board, we really do appreciate the sheer amount of work and the number of meetings and the feeding of the central data requirements that you're going through. So we do really thank you for that, and it's truly impressive. And it's safe to say, of course, that turning things off is much easier than turning things on, and restoring services for the needs of our population are really important. And I know a huge amount of work is going on in that area. I'm just going to pause for a second because I see Neil's got his hand up.
Yes, thank you, Andy. Obviously we all echo those words about our executive colleagues as well. I just had a kind of a question to ask about your report, if you don't mind. And I was just a little bit curious just to hear a little bit more from you, and perhaps also from Lord Mawson as well, about the SHAPE 2030 Partnership Board, because actually I didn't know anything about this new forum being established. And I just wonder if there are any implications that we've fed back from that board into our own redevelopment of our hospital site, or not, or is it very much going the other way around in some way? So I just wanted to get a bit of context from you on what you're learning, if you wouldn't mind. Thank you.
Yes, so it's very new. I've just joined it. So there was a board, which is a Surrey County Council board for one public estate for Surrey. Tim Oliver, the leader of the council, invited NHS representation because of the need to sort of make best use of the whole public estate in Surrey. So Karen McDowell, the finance director for the ICS, and myself as a non-executive representative were invited onto that board. So to give you an example of the sort of things, so at that board level, we're focusing on kind of big opportunities. And one of the biggest opportunities we have, which Andrew will no doubt comment on as well, is Weybridge with the hospital site. You've got the hospital site, you have the library site, you have a community centre, you have a CCG office, all very close to each other in Weybridge, and there are opportunities there to rebuild on one of the sites a really flexible building, whilst maybe releasing funds for transformation from the other sites. So there's a real opportunity around Weybridge to build something more of a centre of community than a community centre, if I can pinch Andrew's words. And that has kicked off, and Well North are supporting us in that. So everybody will still do their own estates bits, but actually at public sector level, it's about how can we work together, how can we reduce the estate and therefore reduce expenditure in order to release it to make the new buildings so much better. I don't know if that helps you, Neil.
Thank you. That's useful extra insight, and I certainly agree with you about the observations around Weybridge. That is an opportunity. So thank you. That's excellent. Thank you,
Andrew.
Yes, well, I agree with everything that Andy's saying. I was invited by Tim to sit as an observer on this board, so I sat there once, and it's very interesting. And I'm getting to know Patricia Barry, who leads that. Indeed, we've got a workshop with her later on in August, and her team and our team, to share what lessons we've been learning in North West Surrey and with the hospital and with the ICP, really. I think the opportunity in Weybridge, we're doing direct work on that now, and it is proving really interesting. But also, there's quite a lot of evidence both there and more widely in Surrey, as I dig into it, of schemes going round in circles and not necessarily making progress. And I think there's a great desire to make progress on these schemes. The scheme in Weybridge, which we're digging into in a lot of detail at the moment, you need a bit the wisdom of Solomon to work out which is the right site, but we may be finding a way forward for that and bringing the community together around a potential solution. We'll see over the next week or so, actually. So I agree with what Andy's saying. I think the Weybridge thing, if we can get it right, is a bit like Woking and some of the others, a real pathfinder example potentially, and a real way of bringing some of these siloed communities and siloed developments together in a more integrated way, both in terms of the built environment, but also in terms of the cultures that need to be far more joined up as we rethink a piece of town centre there. So it is very interesting, and I think there's a lot of cooperation and a lot of joined up behaviour starting to happen, which is good.
Thank you, Andrew. Thank you for that. I think other points on the report, you'll see about the visit of 3 councillors, 1 county councillor and 2 Spelthorne councillors to Ashford. And you'll see the picture there. James did a sterling job of making sure we were all socially distanced and masked up. I did point out that it looked as if we were about to go off on a bank job, but actually the briefing in the car park, so we didn't compromise the infection control, and things worked really well, and the weather was kind to us. Colleagues may not realise just how much estates work has been going on with the opening of the new AMU. The car park is progressing. I mean, it is very close to completion now. I think it's got a month to go. And of course, we've just had the exciting ideas pitched for the front of the hospital as part of the architect selection. The other things I pointed out were the Surrey Safe Care project and a good launch of that, and that's up and running. And indeed, Louise Mackenzie and myself did an induction event for the people who've been brought into that project, which had a very positive response. and I think the whole collaboration piece, the joint working, particularly within the ICP, has been really positive, and the rest of it I will take as read. So Neil, your hand is up. Is that still up, or is that again? No. So any other questions on my report before I hand over to David? Okay, so David, you are on.
Thank you very much, Andy. So like you, Andy, I'll take it that the report is read. I think the first thing to say is obviously I'm not Suzanne, and as we all know, Suzanne was seconded by the national team to do some really important work in the Contain project. And and we spoke to her yesterday, myself and Andy, and she's working incredibly hard and is up and down the country. She's clearly missing everyone, so she wanted to say hello to everyone, and she is due to come back towards the end of September. So just reassuring you, she's on her way. And what I would like to do is just add my thanks to Zach, who's fulfilling. He's acting as the medical director, so he's backfilling some of my roles. So I'm able to do Suzanne's role for this short time. I suppose the report shows it talks about quite a lot of the big changes that have happened during COVID, and you'll hear those come through with all the reports as we go through the meeting. The huge change in the way that we're working. You'll see the impact of COVID in the hospital during the heat of the pandemic, and as you can see, that is now waxing to some extent in the hospital, and clearly our emphasis remains on infection control, and that's to protect our patients, to protect our staff, but also to protect the community. And I know Andrea is going to talk about the new North Star objective in the quality report, and I think it's a really important step forward. It's not replacing the Together We Care strategy, but it's a focus for the next 18 months. And I think when you see the work that's done in the DIPSA report, you can see how much effort we're put into this very important area. I suppose what's now coming along is that after the heavy work from COVID and the impact it had on the hospital, we're now in the stage when we're restarting the work. And as Andy said, that has entailed an enormous amount of estates work as we change our estate round to cope with the new world. That we're enabling our staff so they can work remotely, that we're really putting a lot of services and infrastructure changes into Ashford so that can manage our elective pathway, and how we can get our critical care services in a really good place for meeting any further waves of COVID coming through. So an enormous amount of work, and I think you'll see that as we go through the reports. We've had a couple of important surveys brought back. The Inpatient Survey, which I think was published in July, and again you can see the appendix at the back of the quality report, appendix 2, I think that is. And as you can see, there's been a steady improvement in our response rate, and also the responses within the hospital that we can be proud of. And the word cloud, which the CQC are going to use, are what people say about our hospital. There's also the cancer survey, and we've done well in that cancer survey. There's 2 of the questions that we're doing very well compared nationally, but there are some areas where we just need to improve some of our communication as well. And again, that's at the back of the quality report. I suppose just the other bits, and Andy touched on this, is that the Safe Care programme is now in full swing, and that's an enormous project of transformation across ours and the Royal Surrey's Trust. And actually, I'd like to just recall my thanks to all our staff who are engaging very well in that process at a time when they've had to work very hard on other things. I suppose I'd like to finish off with just talking about two things really. One is the well, three things really. One is the therapies. The therapies move, which we've talked about on a number of occasions, but it is a very fantastic initiative, moving that service out into the community, and just the kind of thing that we're trying to progress more with the ICP. And I think the other amazing thing about this is that they have moved the service, and then COVID arrived and they transformed the service yet again. So it's a really impressive piece. The other bit is that we are going through a piece where we're trying to record our patients' and staff's experiences of COVID. It was really good to hear from Rajiv about how he found his care during this time when he was very sick. But it is very important that we do record this, and we look after our staff as they've gone through this process and coming out. And I know Louise McKenzie is working very hard to make sure those support processes in place. And we're going to record it by a number of means. That's by conversations, by videos, by art, and by pictures, just so we have that in our archives. And I suppose the other thing that is really important for me to say is just to again record my thanks to the community during this time, because the community were unbelievably supportive of our staff and our organisation during this time, and that really helped the staff and the organisation to cope with this unprecedented time. And I have to say that I also think that the community really started looking after each other as well. I mean, there's just some fantastic stories about people, you know, taking food to vulnerable people, making sure that they're all right, and also thanks to all the other providers and social care and community hospitals and primary care and everyone who was helping us. And that was other people sending their workforce that couldn't provide the role that they were doing. So we had people from the airport helping us in giving food out. We've got people from the fire station helping with security and portering, and we've had so many offers of help. So thanks to everyone during this time. I think it's really important that we all make note of that. Thanks, Andy.
Thank you, David. Any questions for David on his report? I'd just like to say, David, I think this was a really excellent report. I mean, I as you know, I read it through the eyes of somebody, a governor perhaps, who's not on site, or a member of the public, as it's an open board, and I think it's so informative and well laid out, and obviously in line with our strategic objectives. I thought it was just a first-class report. Anybody else got any thoughts or comments on that? Let off lightly today, David.
Oh.
I just want to take chairman's privilege for a second, something I forgot to mention in my report, and I tweeted it out last night, but it was a lovely vignette of what we're about, really. And this was in the postgrad centre. I'd just gone for a coffee. I was getting myself and David a coffee, and I was behind two young, very keen F1 doctors who just arrived, and they asked Tony in catering what the times were for the opening, and he duly gave all that, but he then said, well, you're new, what are you going to do? Oh yes, we're F1 doctors. And he just then off the top of his head just went, a real welcome, warm welcome to Ashford and St Peter's, delighted to have you. And they were really chuffed. And I just thought, for a member of our catering team to go just get that extra mile, make people welcome. That's kind of what we're about, isn't it? And it's about it takes a team. And so those of you on Twitter will have seen my tweet out last night about that. But I just thought it summed the culture of what we're about really, really well. Anyway, that's my chairman's privilege bit. We're now going to move on to the quality and safety section, 15.1, and I'm going to come first to Jane for any observations from the Quality Committee that you want us to be aware of. Thanks.
Okay, thank you, Andy. Yeah, there were a few issues that we discussed at the Quality Committee, which I am sure Andrea will pick up. But the main issues were the serious incident backlog and the fact that due to COVID, it has been difficult to close a number of those and the focus on that. The learning from mortality, the committee wanted a bit more information around particularly COVID patients, around location and timing, to see whether we could learn a little bit more from that. So that's something we were going to look at in the future. We were concerned around the surgical site infection, still a significant issue. Pleased to see that the nurse that's been appointed is now going to be moving back in July to focus on that work. So that was a good thing. We know that the complaints performance has dropped, so we were assured by the chief nurse that will be looked at. Numbers are small, but there is something that obviously going out of COVID now, the number of complaints are increasing slightly, so I think a focus on that is important. We did talk about the need to consider quality priorities going forward, particularly with our objective to prevent any healthcare associated infections. So that's something we will need to look at in a future committee. I'll hand over to Andrea now so she can take us through more detail.
Okay, thank you, Jane. And Andrea, you can obviously take the report as read, but we'll be interested to know which way you want to point us at.
Okay,
Thanks.
just thanks, Andy. There's just a few things I just wanted to bring out really. The first one is about the medication safety. That continues to, the work that we've been doing on that continues to show a favourable downtrend on the medication incidents that we're seeing, and also incidents in particular with harm. So that's really good to see, and in particular, obviously, in light of COVID and the face-to-face interactions that we had to pause, but have been reinstated that activity now, that we've still seen the good work done with the team around that, and it's something I think we should look to write up. The second bit was about the mortality, and as we have got the next report, learning from deaths, I know, but just to bring out about, obviously we have seen a peak in our deaths due to the COVID-19. It's interesting just to bring out that the COVID-specific mortality data has been benchmarked against the national data and shows similar trends. What we've seen showed similar trends to that national picture, and with a 6-week increase in mortality. So it's just to bring that out. And then IPC, as Jane's already mentioned, there's a lot of work going on around.
Should I just come in with a bit on that mortality?
Oh, the mortality.
Yeah,
because
I mean, one of the most striking features is how the risk-adjusted mortality index has shot up, which as Andrea says is in keeping with our peers, and I suppose that the risk-adjusted mortality is essentially related. It's calculated on data of, we know, patients when they come in with certain conditions, and I suppose that jump is related because actually COVID's an unknown quantity, so that won't be occurring in the risk-adjusted mortality. There's been quite a few reviews done of COVID patients to see if care could be better, but that explains that jump in that. And I think that the other thing, just to point out on that mortality data, is that if you look at the total number of deaths, you can see again there's a big rise, which was seen in all the hospitals and across the country in deaths. The non-COVID deaths actually reduced, as you can see, and that's the in-hospital mortality. But if you look, you've got some national data as well that just compares on what's happening outside as well. And actually, it might be that actually more people were dying in the community rather than hospital. So the mix did change there. So those are the things to pick out really on the mortality. Okay. The other bit that's added in that report, and the reason why I'm emphasising this is because this shows the data from March onwards, so it's much more recent data. And as you can see, there is some work, and we've done quite a lot of detailed analysis of the work on our risk. the data we have in the hospital is people who are admitted with COVID. So this isn't overall the number of people. As you can see, what we saw was that actually you are much more risk the older you get, and particularly if you've got male sex, and there is some data about obesity as well. The ethnicity side of things wasn't demonstrated clearly in our data in the hospital. But as I said, the numbers, the demographics in our population mean that numbers are quite small, so it's quite statistically hard to see where that risk is, and certainly that's where the national data is coming. And I note there is quite a number of research studies which are now being started to look at what are the risks, what are the drivers for increased mortality in certain groups. So a lot more work to be done on this, but I think there is quite a bit of detailed work in that quality report, and there's more to come.
Thanks, David. Andrea.
Okay, thanks, David. Thanks. So just to carry on, so the other priority we have is around infection prevention and control. It's good to see cases of C. diff and E. coli bacteremias are down compared to this time last year. But obviously a big issue for us, in particular in the end of May, beginning of June, has been around COVID and an outbreak that we had, which is mentioned in the report, that affected 6 staff and 7 patients. Those patients developed hospital-acquired COVID. It was, I think, in light of that, we'd had the first peak, we then had this lull, and it happened in the lull. So I think there was an element of perhaps, staff had become a little bit complacent, thinking that COVID had gone away, and it clearly hadn't. And it was a shock across the bowaways for us, really. What we did was to really, again, refocus on the IPC measures that we'd implemented, our strategy. So it was again about the refocus on the precautions that the PPE, wearing appropriate PPE and the precautions staff needed to wear. The cleaning even more, and particularly around where patients are being discharged and having really deep cleans done in those particular areas. We've gone to 7-day swabbing of all patients to make sure we keep track if there's anything picked up, and also the visiting as well. So we've really, as I've mentioned before, that we've got very strict visiting restrictions in place, and I think it's right and proper to keep those in place at the moment. I know it is causing concern to patients at the moment due to the COVID situation being as it is, and the threat of a second wave, and also the threat clearly of outbreaks happening. It's right that we keep those measures in place. I'm happy to say that once we put a refocus back on the measures, that we managed to grip the outbreak, and we haven't had any new cases now for 5 weeks. So that's been good news, but we're very vigilant around that. And as I said, I think it was good it was sort of an awareness piece really for the staff, that although we might have headed into a lull, COVID is clearly still ever present. Just to pick up on the few safety bits, is around the falls have reduced as well, and you'll see that in the report. And that's down to the interventions that we did implement before COVID. But there's one particular other intervention that we've implemented during COVID, which is called the Bay Watch, and that's being able to cohort all of our patients who are at risk of falls into one bay, and having a permanent member of staff placed in that bay to be able to observe those patients and be able to ensure that patients don't fall. And that seems to have worked very, very well, actually. So that's good news, and we'll continue with that. The Ssi Backlog that Jane picked up, just to mention about that, there is a backlog, but we have got a recovery plan in place, and Jackie Rees, who's our head of our Associate Director of Quality, is meeting with all of the divisions to look at those backlogs and the plans in place for us to be able to recover that in good time. And we're liaising as well with the CCG on this, who are supportive of our plans around that. The other piece to mention is about complaints. Again, Jane did mention that, and performance has gone down. We did have a pause on meeting the target of 25 days from March through to the end of June, but that's ended now, so we're back to business as usual, and we're doing that recovery piece to pick up those complaints that have breached and that are in the backlog. So the team are working hard on that. And around the patient experience piece, I'm glad to say that we'll be introducing a new patient feedback platform in September, and that's with a company called Viewpoint. We did do a pilot last year with 3 companies looking at improving our patient feedback while patients and relatives are in and visiting the hospital. And Viewpoint came out top, and they came out top both on the amount of feedback that was gained through that platform, the quality of the feedback as well, really, really good granular feedback that was given. And also the staff really like the data that's produced from this platform too, really easy to use and in quick time as well. So that was a real positive. So we're very much looking forward to that being rolled out and improving on our patient feedback as we go forward. The only final bit I'd like to pick up on actually is about feedback that we had from the Health Watch, and this is following the Patient Monitoring Experience Group actually, and they've gained feedback from our patient population from over the last few months of being patients with us during COVID. And there was 3 things that they brought out actually, that there was still a fear actually of patients wanting to access our healthcare, and obviously we're still having to work through that. And although we have seen an increase of patients coming into our hospital now and coming into our service, has shown that has improved, but there's still a fear out there around that. But there was great positiveness about the turnaround in ED of patients who have been in ED and how quickly they were turned around, and also about the PPE that both the staff were worn and that they were asked to wear as well. So that was very much seen as a positive. And the convenience of telephone appointments as well came out as a big positive from the feedback that they got. In particular, patients not having to drive here, not having to park and pay for parking. And also there is anxiety of having to wait for an appointment in a waiting room. And so not having that and just being in the comfort of your home doing these appointments was seen as a real benefit. Particular areas that we do need to work on that came out of that was about improving about appointments being postponed or cancelled, and we do see that coming through our complaints actually, and we know that's a bit of work we still need to work on. It still is happening even though with the virtual appointments, and also communication with patients whilst they're on these waiting lists was another thing that we just need to work on as well, just keeping that comms going with them, obviously with the waiting list the way they are. So that was quite encouraging, I thought, anyway, for the positive feedback we've got, and also for the things that we need to work on as well. So it's always good to have that. I think that's it really from me, just for pulling out sort of the main particular points in the quality reports. Happy as ever to take any questions or clarify any points anybody might have.
Thanks, Andrea. Questions for Andrea? I've got one to kick you off, Andrea. Just on the pressure ulcers, I'm just noting that the category 3 for both COVID and non-COVID is sort of ragging at red now, and I'm wondering if what's the kind of story behind that, because we've been doing quite well on pressure ulcers, haven't we, up until COVID? Yes, we have.
Thanks, Andy. So speaking with the tissue viability team around this, there's a few things that come into play, and as you know, we've seen an increase in pressure damage in ITU from patients being proned, but we've also seen within COVID patients actually some skin manifestations that are sort of, it's like a pseudo deep tissue injury that's happening as a consequence of the infection, particularly in the capillaries and this microthrombuli that's happening. So there's some of those particular. So it's not actually due to pressure damage that we've caused. It's something. It's a reaction that's happening due to the infection. So some of those pressure ulcers have been categorised within that. So they're going to go back to recategorise those, because actually it's not truly down to damage that's happened whilst in our care. It's due down to the infection. There's a lot of research going into this actually, because it's a new development that's come to light. So, and work around, I have mentioned before at last board, around the mucosal damage from ITU patients when they're being proned and laid on their front. There has been some good work around that. There's been good work locally done around that and nationally to try and help with that particular issue, and the use of particular gel pads have been brought in, and also different dermal pads have been brought in, as well as different bandages that can be used to secure the ET tube. So that's not compromised, the airway's not compromised while patients being prone. And that seems to have really helped. So that's good.
So that, I mean, that's fine on the COVID patients. That's really helpful. But it was read also on the non-COVID patients?
Yes. So again, the team are doing work around that. I mean, it's a case of, I think that it's trying to get the patients up and mobilised and making sure that as much of the pressure relieving piece can be done. So they're looking into it. I mean, it is unusual, to be fair. But the guys are doing work into that as we speak. So we'll be able to report back on that.
Okay, thank you. I think it may have something to do with moving people around a lot. Of course, with COVID, we had to move people between wards quite a lot, didn't we?
Did. And that in itself has impacted on lots of other issues.
Yeah. Okay, thank you. So anybody else, any questions on the quality report, please? Questions, comments? I know this has been through quality committee, so. Okay, I'm not seeing any more. Final one from me, Andrea. Sorry, I seem to be the one picking things out here. The complaints by division, you rightly say this may be in part to a high number of patient contacts in the MES division. And I'm wondering if we could kind of bring that out by having a sort of the complaints per patient, the per numbers of patient contact, because that would just drive that out, wouldn't it?
Yes. Yes, it would. We can do that.
It's not a lot of extra work, I hope.
No, that's not. I think it's right to sort of bring that out in a bit more detail, isn't it? To put
yes,
the
it would make it clearer then, wouldn't it? That it's not about a particular division being behind the curve. Maybe it's about they've got the sheer volume of patients or whatever. Just make it helpful. And that was it from me. So we're going to move on then now, as I see no other comments. Jane, the minutes for the quality committee, anything you want to draw our attention to?
No, the committee accepted the minutes from the May meeting. Just for the board to be aware, we agreed during the early stages of COVID to submit questions, and the quality committee have continued to do that. So we have the non-executives reviewed the papers in depth, submit questions which we then, I as the chair, circulate to the executives so that we can try and answer those in the meeting, and for the divisions so that the operational leads can continue to focus on patient care. The divisional reports are received at the committee, and any questions are circulated, and you will see at the end of the minutes that the divisions, in a very timely way, provide us with answers so that we are assured, and we can keep that as a record.
Okay, thank you. And it's right, isn't it? At the moment, you're not having the divisional leaders at the meeting so that they can focus.
It's something I think Andrea and I are going to review in the next couple of months as to how we take that forward.
Okay, thank you. So
sorry, Andy, can I just add another thing? I forgot to mention. It's just around the just to note really about the infection prevention control board assurance framework that came down from NHSEI for us to complete, and it's just to note that we have completed a gap analysis against that. There's all sorts of different measures that they're asking us, have you implemented X, Y, and Z, and actually following our gap analysis on that, we're doing really well against it, and so we've fed that back up to NHSIE, and just to add that the CQC now on my monthly engagement conversations with them, they're using that board assurance framework as their handrail to ask questions around infection prevention control. So it's just to note that it's obviously a key focus from the CQC around IPC now, clearly, and this IPC board assurance framework is something that we'll keep monitoring, going forward to make sure that we're doing all that we can against those particular measures.
And does that go to the quality committee then?
Yes, and that going forward, that's now going to be it's going to be a standard item, isn't it, Jane? We agreed that.
From now on, it's going to be a standard item.
Yeah.
And just to say that we have observing the committee, a member of the clinical commissioning group as well as part of the assurance process. They're not a member, but they do observe now. Good.
Okay, thank you for that. Okay, so we're now on to 15.3. Now, Zach was down to lead on this. David, who's leading on this one?
Well, shall I lead off and then
okay,
and join in? So we've got the Learning from Mortality Review report. So this is the Q4 report, and that's why it's important to look at the data in the quality report, because that gives the most up-to-date data. So this report ends just when COVID was becoming a big issue, and you can see that the mortality rate was just increasing at the end. So I think the things to pull out of the one, I'll take it as read. Things to pull out is that there was a deterioration in the initial screening, and as Paul's put in the report, there's a lot of changes in terms of consultants and their working practices, how we're setting up the wards, and that probably led to that, together with the increased numbers that were starting to come through after March. But I've spoken to Paul, and actually this has been turned around. I think the main thing that we need to draw from this is now we've got the medical examiners in post, and they were appointed in the middle of March and started working in April. And particularly Tanya Sarkel, who's the lead medical examiner, she took a very prominent role during COVID with the bereavement team and interacted with lots of families during this time, and I think did an absolutely fantastic job. And I think those being appointed now, I think that's going to really help us drive forward and get these structured judgment reviews performed in a more timely way. Paul tells me that now we're up to 78%, so that is improving as we go through June. The other bit in this report is now that we are putting in place the perinatal mortality, which you can see, and also the criteria from which we put an assessment in place. I think that's all I want to ask, but happy to answer questions really.
Okay, thanks, David. As you say, the quality report is more up to date than this one because this is the last quarter of the previous. Yeah. But questions on this?
I suppose the other bit that I didn't put in place is that, as you see, we have, and I think the question came up earlier in the closed board, we have done 60 random SJAs or SJRs during this COVID period, just to pick up, and actually 30 of those have been completed already. Only one has shown poor care, which is awaiting a second review. But I think that's a good thing to do during this time.
Okay, thank you. I wasn't clear in terms of which of the baby deaths go to HSIB, because at one point they said everything had to be referred, didn't it? And then, so which ones actually do go off to HSIB now?
Andrea, do you know that?
My understanding, it's all of them, but we'll have to get clarification. That's my understanding, but we can get clarification.
Okay, but I'm presuming they don't take many of them up in terms of actually thematic. They all get reported to them. Is that right?
That's correct.
Okay. Any other points for this report? Okay. No. Okay, good. So we then move on to 15.4, and David and Andrea, there's no let up here. Director of Infection Prevention and Control Annual Report. Who's leading?
And Andrea, do you want to?
Yeah.
I think it's a great.
I'll kick this off. Yeah. So as you'll see in the report, we've reported against our IPC priorities for last year. And just to bring out some of the highlights really from that is that we did meet our trajectory of the C. diff. We didn't meet the trajectory of the MRSA bacteremia. We had 2 cases, unfortunately. And there's been lots of work around that to address that lapse in care, particularly around line care, because it was centred around lines that had got infected. The other piece is about that's mentioned in here is about the Norovirus outbreak that we had, which was quite a pivotal moment for us in that it did get us ready, as we've mentioned before, for COVID. But there was a lot of good work that was done around that outbreak that affected so many inpatient areas in our hospital. It was 12 inpatient areas over several weeks that we were managed to, once we'd implemented the measures that we needed to do, we managed to grip it. So the extra measures that really made the difference to turning it around for us and stopping the outbreak within the 2 weeks was the lockdown of the hospital to all visitors, closure to all visitors, the really heightening the strict IPC measures into the entry into the hospital. We removed alcohol gel because alcohol gel isn't effective on norovirus, so that was taken out from everywhere, and good old hand washing was really promoted as it is the gold standard. And then we did do the enhanced cleaning as well, and use the UV decontamination methods, which we're doing now for COVID, as well as the Zunu stuff. But that again did make a real impact. And then really putting in extra IPC auditing and training around measures and what people were doing, and making sure people were adopting the right, and that did make a difference. And another key piece, which we've tried to again minimise during COVID, is moving of patients, which we just brought out, is that the movement of patients has shown that that's a real risk from an IPC perspective, and a risk for patients picking up infections. So those extra measures really enabled us to deal with that situation within that 2 weeks. And as I said, put us in really good stead to hit the road running with COVID. And in particular, because we implemented those measures early on in COVID, we were ahead of the national direction that was coming out, which was good. And we were being asked about, because people could see about our transmission rates, as we've reported before, were low, and what we were doing. And once we articulated what we were doing, it was seen as extremely good practice and informing what was going on nationally. So that was very good. The other piece to bring out is about the SSIs, which we've just mentioned in the quality report. But as you'll see from this report, again, it is a concern, and it is a real focus going forward. There wasn't a great amount of improvements made with changing the dial on this last year. But I think that's in sight of the fact that we didn't have an SSI nurse until September last year that came into post. Now, she's been working extremely hard to try and turn this around, and has implemented, in the process of implementing, 18 different bundles to deal with surgical site infections. So I'm confident that we will start to see a difference with this in this coming year, of making a difference. But it clearly wasn't something that we managed to get a grip on last year. But going forward, we will. And then the influenza was the other bit I just wanted to bring out. We got 75% on the target. This was a sequin that we had last year, and it's expected to be obviously coming this year as well. We only achieved 75%. The target was 80%. There's a lot of good work put on that to try and get compliance. We're up against it this coming year though, because it'll be 100% compliance with this. So we're already starting to have the meetings and working around the strategy of being able to deal with this and get that compliance. It is a big ask to get 100%, but particularly some people just clearly refuse to have it. I think it might be a bit of a different picture this year. It'll be interesting to see. And I think with the COVID vaccination that's looking to come online as well, and I have heard with some reports that it could well be in Surrey Heartlands from September onwards, and the rollout of that will be interesting too. With regards to compliance. So I think I'll leave it at that for the DIPSI report. Unless, David, is there anything you want to add before we go out?
I was just going to add on the surgical site infection thing. So So I think that, I mean, one of Anna's great jobs that she's been doing fantastically is really pursuing and getting the data. So making sure that we do identify and record surgical site infections. I mean, the easiest way to show that you haven't got a problem is you don't look very hard. And she's looking very hard, she's making sure. And I think that really, really does, well, it demonstrates that there is a big problem that we need to sort out. But I think that we are going the right way about it. And I think through all this, we've learned quite a lot of things. I mean, Glynis, who is the infection control consultant, we've learned so much about water and Legionnaires and ventilation systems and air systems. And I think this report is only going to grow and grow and grow as we do more and more things. I mean, it's so much more detailed than it was a year ago.
Okay, we've got quite a few questions. We'll take Neil's first.
Thank you. I guess just firstly an observation connecting back to a conversation we had earlier in the closed board. I'm guessing that actually our kind of experience this winter and capturing this report and feeding into COVID, the extra steps we've been taking, and in particular deep cleaning and education and training, you're in effect now describing the next normal. So that which might have been the standard before is probably not going to be the standard in future, perhaps as an observation. And that's probably the thing we need to think about in terms of our North Star. The question is, of all the things that you have been doing differently in the enhanced climate of COVID, is it possible to identify which is having the most traction, making the most difference in terms of an emphasis for communication to staff and to patients around making the hospital a safer place for infection prevention? Or is it just not possible to identify because the report doesn't really make it clear in terms of next steps? And I didn't hear you express a strong preference one way or the other in your verbal update just a few minutes ago. That was what I was interested in, please.
Okay. So do you want me to go first, David?
Yeah, you have a go.
Okay.
Question.
Okay. So I think we have got a commitment as to going forward that that how we were before we can't go back to clearly, and our IPC strategy that we've produced I think clearly articulates that going forward and what we need to do. And again, that's going back to minimising that human density, the IPC precautions, the decontamination, and also the environment that we need to look at as well. And the IPC strategy very much is a support to the new operating model and supporting that North Star objective. I mean, it's a bold statement. It's a bold objective that we've set to eradicate all health care acquired infections in the next 12 to 18 months. But in able to do that, we need a very, very robust procedure in place. And I think the IPC strategy really meets that and is very robust. And to be honest with you, Neil, I think we will continue with that strategy. This strategy is not going to end in 18 months. It's a live document, and we will continue with that. I think going back to your other part of the question about what things do we think's probably landed the most. I mean, it is multifaceted, to be fair, and that clearly comes out in the IPC strategy. I think the thing that's really hit home with both the patients and visitors and staff is about minimising that human density and the clear impact that can have in preventing cross-transmission of infection. And so that, as I go back to the visiting restrictions of reducing that footfall in the organisation, but socially distancing all of our patients in the organisation now and taking those beds out and able to facilitate that. But also our staff really having to get a different mindset around things, trying to keep distance now. It's a very different landscape that we're in when we're in work now. And obviously the implementation of wearing the masks all the time. You're in the hospital now. If you can't socially distance, you've got to be wearing the mask again. Is a very welcome measure. When that came in, I was delighted when that did come in, because that again has really helped. But I think that's been the key thing for me, really, that's hit home with both staff, visitors and our patients. David, I don't know what your thoughts are.
I think you covered them. I think the true thing is that this is a cultural shift in terms of the danger of infections and who it's a danger to. So it's a danger to the community, to patients and it's to staff, and it's articulating why we're doing things. And I think the biggest change is how people prepare to get and go to work. And I think we've got a long way to go there. But actually, that's where the infrastructure, the estates plan, needs to really align with that and allow people to come in. I mean, Russ was telling me a great story about when he went to the Hereford place in the SAS, and he was talking to one of the people there who was all dressed up in their combat gear, and he'd finished his exercise or whatever. But he said, "Oh, I've got to go and get changed now because I'm not allowed to go out wearing this equipment." And Russ and he went in to where the changing rooms were, and they were fabulous for this facility. And I think it just demonstrates that actually we've got to have the facilities where our staff can go and get ready in comfort, get in the right kit, get clean, get protected, and then go to work, rather than this blurred margin that we've had for many years, which has become more and more blurred. And I think we're all proud of the new North Star objective, because I think it articulates that, particularly that communication and that discussion with the community and the citizens and the staff about why we're doing things, and get that ingrained in our culture. And that other idea that we're kind of going to define healthcare system a bit like an airport, where there's a land side and there's an air side. An air side is a very sterile and restricted area, as it were. So I think it's a cultural shift, Neil, which we're not all the way there, but I think that's what we kind of said.
Thank you. That's both of you. That's very helpful. I think you've confirmed what I was thinking. And David, that last point around staff and facilities, if we're true to the North Star, we can't lose that point. It was a very important point. So thank you.
Okay, Jane.
Thank you. I just wanted to support Andrew in presenting the report, in that when you described the steps taken with the norovirus, I think it really did help to, as you described, set the scene for when COVID came in. So I think you did do that very well in the committee. We did talk about surgical site infections, and we also talked about some particular areas where there may be a particular problem, and the focus now that needs to be on those particular teams. And one of the things around the flu target, which you rightly say is quite a stretch, but we discussed that it might need to be added as a priority in the IPC strategy. So it's just making sure that we keep an eye on that.
Yeah.
And really just to remind the board that we will be looking at the NHS England's infection control assurance framework as an ongoing document to make sure that we are monitoring where we are with this.
Yeah.
Okay, thank you, Jane. Chris?
Yeah, hi. Couple of things actually. I guess I mean, at Amazon, we used to talk about big, hairy, audacious goals, and I think it's good to have those. And I think the North Star objective is one. I do wonder whether it really sort of supports Neil's point. And I noticed on section 12 there was a sort of view on priorities. But you know, are we going to sort of see some stages, I guess, in terms of how we're going to get to that target? To meet our North Star objective, and will that manifest itself, I guess, in some plans? That was my first point. And the second point is, I guess the influenza one just strikes me in terms of slight lack of realism on what necessarily are the consequences going to be if we don't achieve 100%. Has that been thought through or communicated in any way?
Well, certainly on the influenza, consequences haven't been communicated. We've just been told the headlines are that there's an ambition to get to 100%. So we're going to have to work through that.
Is there a rationale for that in terms of connection with COVID at all, or is it just an up in the game against influenza?
I think obviously there's a worry that come this winter, we're not just going to have COVID, we're going to have influenza hitting as well, and obviously norovirus too. So one could argue it's going to be a very challenging time potentially for us. And so being able to at least try and get the best compliance once one possibly could around influenza would certainly help that situation, and in line as well with the COVID vaccination that comes on as well. Once we get a little bit more information on that, would really help with the situation. So I think it's probably on the back of that, because it doesn't make for a very rosy picture going forward if you know, we normally have challenges amongst all of those things, and now COVID's in the mix too. So Tom, did you want to come in?
Thank you. It was really to Chris's initial question, first part of his question around the timing and the plans around this. So I think the question is really what does the plan look like to implement the infection prevention and control strategy and the North Star objective?
And I know it's early days, Tom. So don't
no, I mean, I think my view on that is that really that has to become the refresh of our transformation program, and essentially our transformation program going forward, which we'll be looking at refreshing in the autumn, will be all around implementing the new operating model, the infection prevention and control strategy. And I mean, we've talked a lot about estates, haven't we? I mean, I think there's probably a refresh to the estate strategy, which is really targeted at delivering those elements of infection control that we need to, tackling some of the estates aspects that sit behind some of the SSI data that we've seen, and then picking off the issues around really being a great place to come to work if you need to come to work, and providing the right facilities for that. So I think those are the elements that I think are critical here, and I think the timescale will work up as we refresh the transformation program, and we'll be able to look at that in the autumn.
Thank you, that's really helpful. Thanks for that clarification.
Colleen.
Hi, thank you. Just responding on the flu question from Chris. Yes, we have heard that there's going to be an expectation that we complete 100% of all staff flu vaccinations. That's going to be quite challenging because we know there's quite a number of staff who don't want to have their flu vaccinations. And I'm trying to remember, I think last year we got somewhere between 60 and 70% completed. But you know.
Oh.
Okay. So we don't really have any more information on that aspirational target of 100%, but of course we will support achieving it. I think the other caveat though is that every year when we do the flu vaccinations, we know that the vaccine only contains protection against certain strains of infection, and there can be other strains that it doesn't protect against. So we still see certainly staff picking up flu even if they've had the vaccination. But I think overall, if we can improve people's take up, then it'd be great. And I think the expectation is that more staff will be, the expectation from the centre is that more staff will be keen to have their vaccination. So we'll build on that.
I mean, there's press speculation that it might be made mandatory for health workers. I've seen that in the papers in the last week. So that might be even more interesting.
Yeah, I'll see.
So obviously that's not our decision, but
I think that's what I meant about consequences, Andy. You know, does that mean you can't work if you don't want it?
Yeah, well, clearly if that were to happen, if the politicians were to decide to do that, then there would be all sorts of implications. But I think we have to wait and see, because it's quite a strong measure, that one, isn't it?
There would always be exceptions as well of people who've got other conditions that might be a contraindication, mightn't they?
In fact, Andy, they did propose that last time they talked about it, and one of the options was that if people didn't have it, they couldn't be deployed to the front line, which was not very helpful suggestion. No,
no, exactly. Tom, your hand up again, or is it still up?
Sorry, I'll take it down.
Okay, thanks. Just on the SSI chart, I mean, I know we're in the fourth quartile across everything, which is really quite disappointing. Is that last year's picture as well, and the year before, or is this a oddity in that one year we've dropped the ball, or has this been a consistent theme, bottom quartile? I don't know.
Sorry, go on, David.
You go, Andrea. You go.
I was just going to say, is the chart you refer to the one in 2.9?
Yes.
That chart there. So, yes. So that was from a snapshot. Actually, it doesn't actually articulate it, does it, on here? From It was from June through to October last year.
Data
Actually.
submitted to the
It's feeding into the GIRFT, yeah.
I think.
Oh, sorry, May to October. It does say it. Sorry, yeah.
I think your question, whether has this been long-standing? I think it has been quite long-standing, actually. I think that the data that we're getting now is going to make things look worse because it's much more robust data. But I think it's been a problem. I think, and that's why we chose it as really one of the main priorities last year. And as you can see, there are many things that lead up to this, and essentially you kind of have to get them all in place to really eradicate the problem. So I think it is a long-standing problem. I think we are getting a true picture of how bad it is, which is making it look worse. But we do need to get on and improve it. And as Andrew was alluding to, there are some, and Tom, there are some specific estates things that we need to sort out, such as maternity theatres and various other things that
Okay, well, that's really all in support of the new North Star objective, isn't it? Yeah. So we've just got to move the dial on this considerably.
Yeah.
Okay, I'm not seeing any other questions. Okay, so we now get to, well, Andrea, you're on again. We get to 15.5, Adult and Child Safeguarding Committee Annual Report.
Okay, thanks, Andy. So this is the annual report for safeguarding. So just to highlight, we do have an adult safeguarding team and also a children's maternity safeguarding team, which historically have been separate teams, but have now come together actually to be one safeguarding team. They're led by the head of safeguarding, which is Jane Mitchell, and that's overseen by the Deputy Chief Nurse for Corporate Services as well. So just to bring out some of the key sort of points really from the report, the activity of the children's maternity safeguarding teams have seen an increase on contacts and activity from the previous year. We saw a dip actually from 2017 to 18, but that's gone back up actually to previous years. So we think that's probably just an anomaly of what happened in 2017-18. The activity of the adult safeguarding team have seen a slight decrease in referral activity between April and March up until this year for the last year, and actually of the cases that they've seen, there's been quite a bit around tissue viability management in the hospital, and also discharge processes, and there's been quite a bit of work done on those, as you'll know, obviously with the tissue viability through the harms-free care team that we've got in place now, and Sue Harris leading that team around that. And the discharge processes, the key areas of concern have been around, well, poor communication on discharge, things just not being explained to patients about drugs that they need to take, or next steps that they need to do, or any particular appointments that has led to a poor discharge, and obviously that some of these safeguarding concerns. We've now got in order to tackle this, we've got a discharge transformation working group ongoing to really tackle some of these issues and make sure that people have a good discharge going forward, which will obviously deal with some of these safeguarding referrals that we've had around that. The other bit to highlight is the training compliance, because that has been an issue and one that we've been working on, and we have been working on it quite hard, but obviously COVID then hit, which has set us back a little bit on compliance. But we have got an e-learning package now in place. I've just recently done that myself. It's very good. And so we're trying to put a big push on that around getting our staff to get on and do that, because the beauty of the e-learning package, which quite a lot of our mandatory training has gone to that. Colleen might be able to talk about this a bit more, is that people can do it, at home, wherever actually. They don't need to be physically in a room in the hospital having to undertake it. So we're hopeful that the compliance across the board will go up, but we're working on that with regards to safeguarding. The other bit to bring out is about prevent training. The figures, they're collected nationally. This is obviously around the terrorism bit and raising awareness around that. And our figures show that the current prevent training figures are below, again, the 95% target. with the basic awareness programme, but it's now been incorporated into the trust induction programme, and hopefully that we'll see a better compliance with that. And it's currently at 88%, but as I said, we're doing a big push on all of this. The other bit to bring out is about Dementia Team. Now, the Dementia Team and the Learning Disability Team, we have this last year, due to retirements and people leaving, we have had those teams depleted, which has impacted on those services. I'm glad to say that we've now recruited to those positions, and they're back up to full strength, and I've been in full throttle really going through particularly the COVID situation. So that's good. And so the report does highlight sort of the impact that some of those absences have had, but we are back on track with that. And then so overall, I suppose the activity remains is higher compared to other years, albeit there's been a small drop in adult referrals, but there is a lot. I think it's been offset, as the report highlights, about the complexity of some of those cases. We are seeing more complexity in those. And I think the other thing to bring out is obviously going forward, there is a concern about safeguarding and the impact COVID has had with the lockdown across both the children's services and adult services, domestic abuse, etc. So we're doing a review of our safeguarding teams. It is mentioned in the report that the adult team isn't as big as the children's team. And so we're going to be looking at that going forward, because obviously I think it is very much expected that we're going to hit a bow wave of referrals coming out from COVID, and therefore we do need to make sure that our teams are ready to, in the best place possible to be able to deal with that. There's a business case being formulated to look at all of that, but that is a concern to the teams as to, and we're already seeing in the children's services referrals are already really starting to increase as the lockdown has eased. That's it from me.
Okay.
Safeguarding.
Thank you, Andrea. Keith?
Thank you, Andrew, as well. I really appreciate your drawing out the work that's been done around improving the discharge process. I hadn't picked that up particularly from the report, but I know from some walkarounds that I was doing with colleagues last year now, that when we met with a few patients in the discharge area, that was one specific area of frustration. They would be there for several hours just because they were waiting for the the appropriate reports to come through off the ward, or some other simple sort of element of the jigsaw was missing. And if a certain time frame was missed, that means they couldn't be discharged that day, and that had all a sort of backing up effect and so forth. So yes, it's important that all the safeguarding around that is right, but it's also a very critical part of our performance and our patient flow overall. So I really thank you for the work that's been done in that area.
Thanks. And as you said, it influences on so many different things, actually, as you say, the flow, but just the patient experience as well. And it's silly because it's basic things that people are missing on. It's just being prepared well enough. So we are we have started bringing up lots of measures that are key points that people, reminders and checklists and all the rest of it, to make sure that patients ready to go the day before and are fully informed.
That's good, thank you.
Just to add, Andrea, that with my other hat on, my CSH hat on, obviously they do children's work across Surrey, and yes, there's far more. The numbers are going up and up as a result of COVID, and as a result of families being shut in together for a long time. So I think we can expect much more in this area, sadly.
Yeah. And just to draw out a point about the changes we've made just with the virtual appointments and some of the video appointment, there is concern around that from a safeguarding perspective. If an individual might be getting coerced by not seeing an individual that might be in the room when they're on that call or video, and that's something the safeguarding team are working with the operations team around, just to make sure that it's difficult. It's a difficult one to be able to deal with that.
And there was one thing from the report that I found slightly worrying, which was the support to HMS Bronzefield, because we're dealing with very vulnerable women here. And the fact that we'd held a 50% vacancy within the team, which seems, I don't know if that means there were two people in the team and one was not there, or whether it's 12 and 6, but I haven't got the sense of scale. But are we are we failing to support these very vulnerable women adequately, would be my question.
So I think last year there was definitely, again, a depletion in that team. It is a very small team. So it was 2 people taken out, which had a dramatic impact on that. We've addressed that now going forward, but you are correct. As it illustrates in the report, it did have an impact on provision. And I'm looking to meet up with the governor of Bronzefield prison as well, just to look at, are they happy with what we're providing? Is there anything else we can do to make things better for them? On the whole, they do seem quite satisfied, but I'm sure there is more that we can do to really try and improve that service for them. So that's something we're taking forward.
Okay, and as you said, we're awaiting a result of an investigation there as well, aren't we, on the other one? So we have to await that. Okay, any other questions for Andrea? No, thank you, Andrea, for presenting that. It's a good report, very thorough. Okay, so we're going to give you a break now, Andrea. Well-deserved break as we move on to the performance report, and I'm going to hand over to James.
Thank you, Andy. As you've said, the restoration of services is really taken up our time. In fact, we're drawn into national reporting, local reporting, and Heartland's reporting. We're doing more reporting on recovery than we were doing on COVID, which seems incredibly hard to believe, but we are. We're doing reports 2 or 3 times a week on this. So it's becoming really, really onerous and taking up a lot of time. And it affects every level of the performance report this week or this month, from ED, cancer, and everything. In terms of ED, our performance dropped to 89%, or the footprint of 92. But predominantly, as we say in the report, that was around segregating our EDs. So we are still having green and blue pathways through our ED at the moment. We were during June. Our beds significantly reduced due to social distancing. So at the point through June, we were 96 beds reduced due to social distancing requirements. As we went through June, we mitigated and managed to reduce that by putting in place some actions, but that had an effect on flow. You can see in the report that we were getting busier through ED. At the point, we were around 235 attendances a day compared to our sort of 300, 330 normally pre-COVID. But the beds that we were able to flow into were reduced. So that gave us an issue. And the other thing that created an issue during June that affected our ED performance was our CT point of care testing that we were using to identify what was the best place for patients to go. And that held up, that caused us some delays in the 4-hour standards during the month. So we were midpoint in the pack. You can see in the report around pretty much middle in terms of national performance. In terms of electives, I mean, we're at 61%. We're a lot less than that now, about 49% RTT as we sit here now. But the standard that we got to work to is getting to 70% of COVID activity and then 100%. And that's where we're working to at the moment. You can see, though, despite the challenge, we are actually ahead of local peers in terms of our RTT. But we're balancing with the private sector, so we're still using and we continue to use and rely on the Runnymede for their theatres there. And during end of June, we dropped down to 1 theatre that we're using with them because they wanted one back, and we've got 1 theatre, 1 ward there, and we've got 1 at Woking Nuffield. We had a challenge with our theatres at Ashford, which meant that we were trying to focus activity on the Ashford theatres, but unfortunately, due to air conditioning challenges that we had when we turned things back on, that knocked us out for 3 weeks. But we're back on track there now. So Ashford is our elective site. So we were making that our elective site. As you remember, we've approved a case here at the board, but we've ramped that up. So all of our elective activity, 90% of it, we're hoping will go through the Ashford site. So we've got the new theatre being built in August. And that will be enable us to be the focus. And that's St Peter's. We aren't doing any elective work in the St Peter's beds. The only work that we're doing at St Peter's in terms of elective is those cases that need ITU or HTU and paediatric cases. And during June, we moved our paediatric wards back over from the Runnymede back to their original place in Oak and Ash. So we've been able to restart some of the paediatric elective activity. But again, it reduced our beds slightly because we had gone into that area as an expansion medicine capacity. In terms of outpatients, we've had some really good work here as well. So we're up to during June, we're up to about 75% of our pre-COVID activity, predominantly through our adoption of virtual technologies, predominantly the telephone. But about 70% of our consultations are virtual, and that's enabled us to keep the service going and actually get people through the system still. And we've focused our outpatient activity at Ashford and Woking, and we've set the new outpatient templates around our face-to-face and virtual requirements. So we've locked in what we believe are the face-to-face requirements of each specialty, working with the teams and allocated rooms on that. So we've been able to keep St Peter's rooms pretty much free for virtual clinics to reduce the footfall on the main acute site. And again, diagnostics is focused at Ashford and Woking again, so we've turned on some of the specialty stuff, some of the specifics at St Peter's. So there are handfuls of things that we've had to turn on where we have £1 million worth of kit that we can't move, but we have moved things to Woking and Ashford. We've moved some imaging equipment, DEXA scan and things to Woking. We've been able to extend our use of our MRI at Ashford and go into the weekends. So that's how we've been able to get our capacity up. I think it's just important to recognise that we are moving stuff away from St Peter's at the moment to keep footfall away from the main acute site and support our IPC strategy. And in terms of cancer, you can see we've achieved our TWR, but like all things, we were doing the most urgent cases. We've been able to turn that back on now, and in the report, actually at the back, you can see where the longest waiting cancer patients are. It was something that one of the committees asked us to pull out, and that was upper GI and colorectal surgery, and that related to endoscopy, which we've talked about already today. If there's any questions, I'm happy to take them. Restoration is taking up a massive amount of time through all the work we're doing across the system and in the trust, and not just turning things back on, but turning them back on in a socially distanced way, an IPC way, and across different sites as well, which has particular challenges. I mean, we're well on track to be at 75% of outpatient and diagnostic capacity. In fact, diagnostics, we're well over 90 at the moment through the way that we've rearranged services. I'd say electives has been challenged because of the unfortunate challenge we had around air conditioning when we turned everything, we looked to turn things back on. But we have plans to, moving forward, to get that back to at least 75% and then onwards to pre-COVID levels.
James, the problems with the air conditioning, I presume, were just because it had been off for a long while, but we were always going to refurbish 2 theatres at Ashford, and that included the aircon. So has that part of that been done then?
No, it's been done enough to let us use it for the next couple of weeks, but we're using it in a very defined set of procedures and circumstances. We're using those 2 theatres at Ashford.
Okay. So they're still going to be refurbed anyway under the programme?
Yeah, and that was a massive piece of work. I mean, under the £5 million that was 2.3, I think, was to do those 2 theatres. So we certainly haven't done that in advance. No.
Okay, just checking. So I know we've seen this performance report at both Modern Healthcare and Quality Committee, but has anybody got any other questions for James on this report? Merrick.
Well, it's really just say thank you, because with so much changing in the operations space, the clarity that you've been able to bring, James, with your written part of the executive summary, which goes on for more pages than you would normally see, but rightly so, I think is really clear. There are no easy answers, and I think one of the things that we reflected at in terms of in Modern Health when reviewing operations is, with everything shaken up around normal working practices, we've seen an ability to compare with others as a guiding reference rather than some of the normal standards, and to iterate where we're not where we want to be, and improve and get into place. And we see that reflected in the beds reduction from COVID, which at worst was 30% and it's now got down to 14. And some of the other key performance metrics, particularly around A&E. So So thank you to James and the team for really a tremendous effort there.
Thanks, Matt. I mean, it is ongoing. You can see that we've got challenges around ED, but it's the scale of what we're trying to do at the moment, which is a challenge, and on every front, on diagnostics, outpatients, electives, cancer, the ED, the whole piece is affected. There's been a real push nationally for some big bids that have come through for capital that we've been asked to, sometimes offered and sometimes asked to apply for, on very specific things coming out from the national team, because there were concerns around space in EDs and diagnostic capacity and other things coming up to this winter. In this winter, we've talked about the impact of flu and what that could do, but we're still being asked to model for a potential resurgence, and if that was to coincide with a difficult winter, that would be a really difficult challenge for what will be for every hospital.
Yeah. Okay, thank you, Marek. Any others for James before we move on? Okay, thank you. Thanks, James. Good report. Merrick, Modern Healthcare Minutes, and then you're on for the annual report.
Is that way around, is it? Okay.
It's only, it says so in the agenda. If you
okay,
want to take
fine.
them the other way around, you can.
No. I think that's the better way to do it, actually. So thank you for that. I will touch on both the minutes which we have in front of us for May, and then obviously talk about the meeting we've had this month in July. So in May, we spent a lot of time understanding the impact on performance on many things that James has obviously taken us through now. But also one of the things that came out quite markedly was the level of staff sickness or self-isolation. And I think it's often, forgotten about that in the context. The impact was very significant. We also went at some length through examining the financing arrangements, which effectively is a block contract with a top up to bring the trust back to break even. And we spent some time on looking at the refurbishment of the Ashford theatres, which, as James said, related in part to our pre-COVID address to the winter issues impacting on elective activity, of course, in a post-COVID environment even more so. Moving on to the July Modern Hospital meeting that we've had, I would say we continued in that meeting to see very good assurance around COVID spend, and in fact the trust is modest compared to many others in terms of claiming certain spend increases are directly driven by COVID. It's an ambiguous area. There are many different ways you could look at it, but as a committee, we were assured that the level of control and rigor and analysis around that spend was in place. We discussed at length the temporary increase in endoscopy, which we'll see more about in the open board in future meetings, but that was a particular area of focus. And of course, it's an address to the significant impact on diagnostics around COVID. And we had a follow-up meeting to further explore elements of that, which were covered at this morning's closed meeting, where we approved the expansion to temporary portable endoscopy units together with related staff for a period of 12 months. We recognise that within the things that Modern Hospital does, virtually all of our key reference points around where we should be and our efficiency and performance are currently taken away from us. And of course, the new operating methods we're going to be running to, James and the rest of the team are working on now. So we recognise we are in uncharted territory in terms of getting the right level of assurances, because it is a very difficult place to be. So that will be a developing space. The other thing we've touched on is the uncertainty of funding, because the funding arrangements, Simon, correct me if I'm wrong, are in place up to the end of September, and we don't yet know what they are going forward. Up to September, effectively, we are fully funded to break even. Couple of final points. One is the risks around all of this. Tom also attends the Modern Hospital, and those have been reflected through into the risk register. And really, finally, a thank you to all of the teams. A special thank you to Simon and James and their teams in the tremendous work that's been done in these difficult times.
Okay, thank you, Marek. Any questions on that?
I'll just add to Marek
Yep.
if I can. The financial framework is due for further announcements this week. Whether it'll happen or not, I'm not too certain, but Marek quoted September. It may well be October by the time that's implemented and through. So considerable debate at the centre of the NHS with the Treasury over how those frameworks will go forward. But as soon as we know, we'll circulate that outside the meeting.
Okay, thank you. Okay, Marek, back to you then.
Yeah, so I'm really going to say very little on this. Is the requirement to reflect on the last year, last 12 months of Modern Hospital Committee. We believe that we are compliant in what we have set out to do. I think subject to, of course, as I've already mentioned, many of those reference points simply are not applicable for us in the current environment we're in. But I'll take any questions on the report.
Okay, thank you, Marek. So any questions on the annual report for the Modern Healthcare, which is very clear and concise? No, I think that's fine. Thank you very much, Marek. Looks like no questions on that. Thank you. So we then move on to the minutes from the People Committee, Marcin.
Thanks, Chairman. The May meeting with the focus was on our HR response, particularly in 3 areas: ensuring safe staffing levels, our support and guidance to managers, and our health and well-being support, which has continued to be a focus at our April meeting, our May meeting, and our last meeting. So I would take any questions on the minutes, or I will, and I would also like an opportunity just to update the board on our meeting that we had last week. Are there any questions on the meeting minutes? So I think what the key thing to say is what's evolved, and it's quite a strong position, and the team have worked incredibly hard to achieve this across the trust. Our vacancy, I mean, since I've been here, I've not seen a vacancy or a factor as so low, which is currently at 2.5%, which is outstanding. We've also seen 200 new staff join us in terms of volunteers coming back from the NHS, or in times of that they currently don't have a job. Whether they stay with us or not has not yet been determined, but that still shows you a massive amount of new support. We've also recruited 332 nurses that will be coming on stream across the financial year, which is more than our vacancy rate of 243, which shows you how successful we've been at our recruitment. But it also allows for the normal process of some applicants dropping out or moving on. I'd also like to point out that our sickness levels from COVID have dropped considerably. We now have currently 39 staff off with COVID, 30 of which have been tested and 9 were outside of the testing framework. This was the one issue that the team are still working with, the 85 staff who've been unable to work, i.e. they're shielding from COVID, but their role meant that it wasn't something that they could be reassigned to. So they are working with those 85 staff as the shielding guidance ends on the 1st of August, and we'll need to sort out how we support those staff going forward. It's worth just saying our testing results for our staff are still standing at around 22% positive, and their families around 21% positive. And the last thing I would like to just focus on is the big task that everybody has been doing in terms of a risk assessment of all staff. not just BAME staff, all men staff, all men, all men, and all people with health conditions. They gave us another incredible target of 100% by the end of July, which is tomorrow. And I'm sure Colleen can tell us, but as of last week, we were already at 73%. Our BAME staff, we were at 63%, so I hope that's moved on as well. We may miss 100%, but it's been an incredible effort by everybody. And I think that's a testament to our HR team that have been leading that. In addition, we just had 2 annual reports that's worth mentioning. One is our annual Guardian of Safe Working, assessing the junior doctors' contract. And I'm pleased to say that this year our exception reporting has decreased, which is positive, but we still have an issue of some unfilled and uncompliant rota gaps. And they're looking to ways of how they can address that. And we also had the annual equality paper. And I think what was the most concerning issue that we stressed and discussed was bullying and harassment. It's still higher at our trust above national average, and I think there's plans in place in which to address that. So I think that's all I'd like to say, and any of my colleagues who are at the meeting, please feel free to speak. And Colleen, if you'd like to give some updates of the figures, that would be fantastic.
Yep, certainly. Okay. Thank you. Shall I do that first for any of the questions?
Yes, Colleen, do that.
Yep. Marcine's correct. The figures for the antigen testing haven't changed. Actually, we're still at 22% of staff who are being tested are shown as positive. And the antibody test is what's quite surprising. Only 20% of those people who are being tested are shown as having antibodies. And of those who are saying that they were symptomatic, it's 40%. So it's quite interesting to see that. And in terms, so the piece of work that Marcine mentioned about the risk assessments for everybody, we've had a really big push on it. It's so important to make sure that everyone is we're aware of all the situations that we need to support people with. So we have improved. The figure for all staff is at 86%.
Excellent.
For BAME staff, it's up at 87%.
Brilliant.
And for everyone who's categorised as at risk for one reason or another, whether it's gender or underlying health conditions or ethnicity, we're at 88%.
Super.
And still 24 hours to go before we have to report. So the HR team are chasing. So we're aiming for 100%. We'll see where we get to.
Thank you.
Okay, thanks, Colleen. Neil?
Yes, thank you. Just as a member of the People Committee, I'd like to support the comments that Marcine has made as our chair. I mean, this was an extraordinary effort over the last few months from the HR team and obviously supported by colleagues across the trust, but to actually bring on board so many new staff colleagues and also demonstrate really good levels of care and attention to staff well-being has been an unbelievable stretch. And since I do this in my day job away from the trust, I can understand exactly how much work they've put into it. So I wanted to offer my own support and thanks. An observation that I didn't make at the People Committee, which I'll make now, which I perhaps should have done, was that historically, we were worried 1 to 2 years ago about when we brought new people in, whether we were actually going to be able to keep them. And therefore, we had quite a big focus on retention. And it clearly isn't easy to onboard and bring people into new work situations in extraordinary times that we've been facing. So I think that as People Committee, we will have to keep an eye on those new entrants and look at our retention rates, because the maximum period of vulnerability for staff turnover is normally within the first 3 to 6 months of starting a new position. So it looks like we have a very healthy pipeline, but our situation could deteriorate again if we don't keep an eye on how we're dealing with all the new people who are joining our trust. So that's probably something which, as People Committee, we will end up looking at again in the next year, and I should probably have raised it when we had our last meeting, but didn't do so. So, Marcine, my apologies to you as chair to raise it at this meeting, but I think that's just another observation that we should reflect on.
Thanks. Thank you, Neil. Andrea?
Thanks.
You're mute.
Thanks.
Yeah.
Thank you. Just unmuted. Sorry. Just to again just say thanks to everybody who's done a tremendous job, HR and all of the particular clinical individuals, Matthew Barker as well, who's worked hard to try and turn obviously things around. There's just a bit I'd like to highlight is around the I've been asked to get involved with the regional team around an NHS reserve coming into place. So they want to try and capitalise on all of these returners that have come in light of the COVID situation and try and get them to remain to stay as part of what could be this NHS reserve. As you know, the military do a reserve, the police do a reserve force, and so they feel there's definitely utility in an NHS reserve force as well. So that's something that I've been asked to get involved. I think it's just on the back of my military experience as well, I think, with this. But it would be managed locally. So it would need definitely resource being put in, but it's in its embryonic stage at the moment. But it's just to flag that up. That's a piece of work that's happening that I think will be rolled out nationally, to be fair.
Yes, we've been. So, if can I reply on that, if that's okay?
Yes, certainly.
Yeah, we've been asked if we're interested in being a pilot for it, along with some of our neighbouring regions as well. And yeah, very happy to support it. I think there might be some funding available to help with that, so that might help with the resourcing side. Although I have to say that the one Marcy mentioned about the number of people that stepped forward to come and help us, either because they were furloughed or because they were available, and it was just incredible how many people wanted to help, either genuinely volunteering as being part of what our normal volunteers do, but also people who were volunteering to do a job of work and be paid for it, and we recruited and cleared a lot of those people as well. We also had quite a number of over around 50 students, nursing, physiotherapy and medical students who were given temporary registration to come and work for us as well in their second and third years, and that's been really positive. Unfortunately, the one aspect that we weren't able to capitalise on fully was the bringing back staff, those people who were just out of practice or taken early retirement, because a lot of those people had stepped out of clinical roles because they couldn't be patient facing, so we couldn't make the most of them, but we referred them on to other partners to see if they could support those areas. So I think so the reserves is a great idea, but we need to be really clear on what contribution those people can make to an acute hospital setting as well.
Well, I think the ambition is it can cover all of the different employment groups. You know, it's not just nurses and doctors, it's porters and IT specialists, it's everybody.
And is the idea that people would be called on in a sort of national emergency, or is it a sort of an enhanced bank?
So it's like the plan is to use it as the military template. So you are committed to so many days a year to work, and yes, there would be a surge if there was a national reason to do that, like with COVID. So they're just working through that at the moment, but it was it's been looked at as a set commitment that you would have.
Okay, well, thank you. All right, and thank you, Marcin, for that. Any other comments on the people side before we move on? Very clear. Thank you, Marcin. Okay, we're now going to move on to regulatory. And Keith, you're on for both the committee minutes and then the annual report in terms of reference.
Yes, so I'd like to take you to paper 17.1 first, which is the minutes of our meeting back in March. I will just draw out for your attention the fact that we do an annual review of overpayments and our recovery rate of those. I'm pleased to say that has been improving. It'd been an area of weakness, and it's been good to see us making progress in terms of keeping track of people who've left and recovering overpayments that have occurred. We've made good progress in our internal audit catch up in terms of outstanding recommendations and getting management responses on those and the implementation of improvements. So that's again progress that we've seen in the previous year. We looked through the annual report ready in terms of a draft for the annual plan and things to go, sorry, the annual report and accounts to be presented. This meeting obviously took place in the week before the lockdown, so it was just at a turning point. And then we've anticipated the impact of the lockdown. The annual plan has had to be rescheduled, and so quite a lot of audit work, both internal and to some extent external work, also being reviewed, but certainly the internal audit plan has had to reschedule some of the timing of work for this coming year. Counter fraud had a very quiet year, but just before the close of the year, 3 new incidents or suspicions have been flagged, and those are currently under investigation. And the then we finally, the thing I was going to say, we reviewed our terms of reference, and we've made some significant changes to those, and with the next item of business is we'll be bringing those updated terms of reference to you for adoption. So that's all I wanted to highlight from our March meeting minutes. If there are any questions on that.
Thank you, Keith. Any questions for Keith on just those minutes before we move on? No, Keith, I think free to move on.
Thank you. So our terms of reference, we've consciously wanted to strengthen the description of our responsibilities and the work we're doing in the area of risk, reflecting the change in our committee's focus and emphasis as a result of these new strategy put in place a couple of years ago. So that's now reflected in our updated terms of reference. And then otherwise, our terms of reference haven't otherwise changed significantly. So if there are any questions on those before I put those to be adopted.
Any questions on the terms of reference specifically first? It seemed very sensible to me, Keith. Very clear. Okay. Okay, I think we're
good.
Happy to approve those. Yeah.
Thank you. I think Simon's going to take the next item.
Okay. Yeah. So nothing else on the annual report, Keith, you want to do?
No, thanks.
Okay. Okay, thank you. So 17.3 then, review of scheme of delegation and SFIs, Simon.
Yeah, so hopefully relatively straightforward. We've obviously required to do an annual review of these processes. It went through the relevant committees early on in the year. Effectively, all we're changing is kind of names, both external and internal. We're not changing any of the scheme of delegation in terms of limits or anything else that's proposed in here. I think you've got the scheme of delegation in front of you. We didn't actually attach the standing financial instructions. I think that's simply because of the length of them and the minimal changes to names, etc. So I think those are available if anyone wants them, and obviously they'll be on the website in due course. But essentially, no substantial changes is the position here, Andy.
Yeah. Yeah, thanks. Liz, can we make sure the SFIs live in the reading room? Because that's the obvious place for them, that we can all go and get them then if we need it. And things like the trust constitution should be in there as well. I know they're on the website, but...
Will do.
Any comments? So we've got Marcine first.
Thank you, Chairman. I was, pardon me, Simon, I was reflecting as to whether we should amend these in light of your new operating model with gold and silver commands, so that we don't have a replication of issues where we couldn't follow the scheme because of the way you're operating under post-COVID.
Sure, yeah. I mean, you raised this the other day, didn't you? I personally don't think we should, but I do think we should highlight the bronze, silver, and gold arrangements as a kind of addendum to these. You know, fundamentally, these stand throughout the challenges and period, and I think, as we noted earlier on the day, compliance with them is really important. So that would be my proposal to address that. Really, just by an addendum, I think is probably the sensible way. But I'd open that up to anyone else's views.
I think Simon, I think I'm kind of probably with Marcin here, that we've probably, given that our response in a level 4 incident was absolutely rightly, to have the kind of A and B teams, so we could go to 7 days. We probably do need to say, in the event of doing that, and of course, you know, epidemics taking. Don't know what happened there. Sorry.
It was the key important statement, Andy.
Yeah. In that we, you know, when in those, and if people are taken out with illness, etc., we probably do need then to say something about duplication of responsibilities. So I don't think it's something we're going to fix here now, but I think perhaps if you could go away and sort of look at that, providing other board members are supportive of that. Marcin, what do you think?
Personally, I think it's essential, because if you don't, then when you do make some decisions and go out for tendering in such circumstances where you don't follow them, you're in breach, and that should be reported through your governance arrangements. So I think you should cover yourself by saying you're operating under a different model, and under those cases you would apply these rules. Therefore, you're a bit more transparent with your governance. It's my view.
Agreed. I was just not proposing to rewrite the whole scheme of delegation, if you see what I mean. I was proposing to put an overlay over that with the relevant detail in. I think with execs we can draft that and come back through the process with those highlighted perhaps next time.
I think it's, you know, just make it clear it's just in certain circumstances.
Exactly.
With the, you know, and this is what we'll do. The appendix says, you know, the SFIs apply except, for example, when there's a level 3 or level 4 emergency.
Yeah, agreed.
Yeah, okay. Colleen was next, I think.
Yes, thank you. It's only a small point, but where we mention the nominations committee and the remunerations committee, strictly speaking, it should be the nominations and appointments committee and the remuneration and appraisal committee.
Very happy to
formal documents. Yeah,
we'll make those adjustments.
That's all. Thank you.
And as you know, Colleen, we're in a state of confusion as to who chairs which.
No, you're not. My papers were. You're not.
David.
Well, I was just agreeing with you and Marcin, actually, that we just need to be clear that in exceptional circumstances, what then triggers, so we don't have this confusion. I think that's all. So it might be an appendix, Simon, but I think it just has to be clear in that.
Yeah, we'll attach it into the relevant bit. Yeah.
Okay. So with that caveat, that we'll see that bit again, Simon, if you could bring that specific piece back to us.
Yeah, exactly.
Are we prepared to approve these? I think it's an approval, this one, isn't it? Yeah, it is.
Yeah.
Marcin, you got your hand up?
Oh, sorry, I'll lower it just to say I approve subject to those.
Yes. Yeah. And you've got your hand back, Marcin.
Oh my goodness, I'll lower it. Lower my hand. Am I lowered or raised?
No, it's raised. Now it's good.
Thank you.
Good now. Thank you. And well done for getting your hand back. I'm not sure how that happened. So, okay, so approved subject to that change, Simon.
Thank you.
Okay, and we now move on with David. We've got the NHSI self-certification.
Do you want me to take this one, David?
Yeah, I was looking a bit confused.
That's all right. That's all right. For the video, though. So essentially, this is the second of our governance approvals. We did one earlier in the year. Really, this one's focused on our corporate governance kind of statements. Again, there's nothing particular to highlight in there, other than this year the process for kind of formal notification of this up to NHSI has changed. There's no requirement, but we are required to evidence that we have looked at this, the issues in the paper. Really, it's all set out in there though, and I don't think either Sal or myself are highlighting anything in particular.
Okay. Any comments on those? So these are these an approval? It is an approval, isn't it, of a self-certification?
Formally,
rather than receive.
Yeah, exactly.
Yeah, we've got receive in the agenda. Okay, so happy to approve that. Yep. Okay. I see no. Good. Right. So we now have a COVID-19 BAF update on the agenda, and we've got who's leading on this. Sal, are you leading on this?
I'm happy to. David, would you like me to?
Yeah, can you Sal?
Okay. So the board will remember that at the start of the COVID pandemic, we agreed to bring an update on the board assurance framework to each meeting. And this update contains 5 suggested changes to the risks contained within the board assurance framework. The first is to reinstate a modern healthcare committee risk and reflective of the current financial challenges brought about by the COVID pandemic. There are 2 suggested increases to risk scores. The first is a modern healthcare committee risk, and the second is a strategic change committee or collaborate risk, which was agreed earlier on today during our closed board meeting. And finally, there are 2 suggested scores to be reduced for people committee risks, and these were following discussions and assurances received at the people committee just last Friday, where it was felt by the committee that the scores in terms of the likelihood could be reduced, and they're being worked through for approval at the next committee meeting. So 5 changes in total, which I think is reflective of the dynamic nature of the BAF as we are at present. Happy to take questions.
Okay, Sal, and I assume that all of them have been through the relevant committees anyway.
They have, and as the committees just met last week, this is a very live document that I bring to board. In that these are the changes as discussed at the committee, and they need to work through the normal governance process of being reflected in terms of the controls and assurances at the next round of subcommittees.
Okay, Simon.
I was just going to highlight in 2.1, the need for the risk had been discussed at the Modern Healthcare Committee, but the wording of the risk hadn't been. So that was my suggestions following those conversations. So the board may want to just consider the wording of that in a bit more detail.
Thank you.
Or we can pick it up at Modern Healthcare next time in a bit more detail.
I think it should be picked up in Modern Healthcare first.
Okay, very happy to do
that. Chris.
Yes, also just a small point on digital and cybersecurity. That is being discussed on the 6th, so that will come to the next board.
Okay, yeah, and that's right, because it's supposed to be a dynamic document, isn't it? So that's absolutely right, as fitting in with the committee meetings. David?
Well, I was just going to say, just a thanks to Sal and Abigail for doing a lot of work on our risk registers, and I think we are looking at them more thoroughly now. The divisions are now going through them. We've got a process through the risk scrutiny committee, which is going well. And I suppose that in light of that, it would just be worthwhile everyone just looking at these risks and seeing if they're articulated in the right way. I think we are getting a bit more coherence. But I was just looking at the quality ones, and actually, Andrew, I think we just need to sit down and have a look at those and see are they articulated with all the stuff that we've now talked about in our quality report and our infection and everything. So I think it's really moving on risk, and it's just talked about so much more at the moment, which is good, but we're still not quite there.
From my perspective, David, that's a massive result.
Chris, have you still got your hand up?
Yes, sorry. Also, Marcin mentioned at I think it was just on one of the weekly calls, the requirement to look at the BAFs in more detail around controls, around assurance, and link that back to KPIs. Now that's evolving on the digital committee, but it's something Laura and I are going to do together, and then we're going to discuss with Tom and Simon, for example, Marcin. But I think it's something, I think Marcin, you mentioned that all the chairs should actually do with their committees. So I just wanted to make that extra point in terms of what David said as well. We're, you know, as NEDs, we are also looking at this in a very focused way now.
Good.
So I'm quite keen that we now move this on to the KPIs that then creates the BAF dashboard. And I know that Simon and Sal and I met, and we have plans to do that. And what Sal needs to do is we talk to each chair of each committee and each executive member just to make sure that that's on the agenda for the next round in September, so that we actually pin this down and get the KPIs reporting.
Yeah. Agreed, Marcin. It's moving forward, which is good, and thanks to Abigail as well, Sal, and the fact you've still got most of your hair, I think, is a real compliment. Let me just check. Right. Okay. That's the BAF. So the trust seal. Simon, is it?
Yeah, sorry, that's me. God, this is a memory test, isn't it? I believe we approved the Pax, Riz and Highland. I would call it a contract extension, but the Highland bit was a disaggregation from that. I think it was back in March at the Modern Healthcare Committee. It might need Sal just to check those dates. And this was just catching up with the actual sign off of that. The new contract or new arrangements went live 1st of July, I think, and we signed this off about the 2nd of June, something like that, Andy. So completion of an earlier approval, essentially.
Okay, that's fine. Thank you. And we move to the final one. Sal, I think Simon, are you going to do this one? Right.
Yeah,
I'll
do this one. Again, this was when we split. I guess my role, as much as anything, into two, as we were initially going into the COVID arrangements. Paul Doyle, my deputy, acted as me essentially for the 4 days that I wasn't there each week. And just for around the SFIs, and back to Marcin's point earlier, there was a need to ratify that decision. I think, although we discussed it with Andy, yourself, and David, we didn't get a second NED approval, which was just oversight on our part. As it happens, we never actually had to sign anything off under those arrangements, and we've obviously since moved out that A and B team arrangement. So again, it's ended that arrangement, but it's just to note that really as that was our response really.
Yeah. So what this is then is we're seeking retrospective board approval because we did approve that. As it happens, we didn't use it.
Exactly.
And in future, as we've just talked about on the SFIs, we won't need to because it'll be clear.
Exactly.
So that's kind of where we are. So it's just to make sure that we're transparent on this one. So can we just approve that, please? Speak up if.
Thank you.
Okay, thank you. So any other business? I haven't had any other business notified to me, but has anybody got any other business? Before we deal with questions from the public, just if you, as we're recording this, just an apologies to those of you who are listening and expecting to hear a patient story at the beginning of this board meeting, but there were recording issues. So what we will be doing is seeking permission to do a retrospective recording of that particular patient. It did happen. And it was a wonderful recording, but a wonderful discussion, but unfortunately it wasn't recorded. So we will seek to do that in retrospect, but apologies to anybody who's listening and expecting to hear that. So questions from the public. Now, for some reason, they're not on my agenda. They're not on my pack. Are they? I know we've got them. Sal, have you got them?
Yes, I'm just bringing them up. Bear with me.
Have the execs had an opportunity to look at them?
I would need to refer to Liz, who circulated them.
I have circulated them to the relevant executive, and I've responded to David Mason and said that we would be responding to him in due course. So I don't think we were expecting to answer the questions here.
No, I was going to articulate them here, and if we can answer them here, we should do. If we can't answer them here, or we need to look at, we'll obviously take them away and respond. So, do you want to read them out, Liz, if you've got them there?
Yeah, I can read them out.
Or Sam, whichever.
Do you want me? So the general observation. So these are all from David Mason. And his general observation is, with the decision at the turn of the year to reduce the number of board meetings held within a financial year, together with the fast-moving and ongoing COVID-19 situation, would the chairman please consider an increase in the number of questions which individual members of the public can field from the current level of 2 to 3? And
right, I think that's an easy one to answer. So I think it would. People may submit 3 in priority order, but if we've got too many questions, then we would only take 2. If we've got the time, we would take the 3.
And then question 1 on the paper 15.1, the quality report. The report emphasises on both pages 1 and 8 that our excess mortality is due to COVID-19, as opposed to a proportion of non-COVID-19 mortality in the national figures, which may well represent community-related deaths not in our data sets. And his question is, what work has the Trust carried out to try and establish if any of these community-related deaths are victims of the overall strain that has been put on healthcare by the COVID-19 response, in brackets, cancelled appointments, together with diktats from both government and the Chief Executive of NHS England, Simon Stevens, who I understand wrote to hospital chiefs on the 17th of March, telling them to urgently discharge patients.
Shall I answer? It's a very complicated question. Do you want me to answer a bit of it now? I suppose it is that yes, we are looking. I suppose we're doing, Andrew, aren't we, doing some very detailed work on patients going from our hospital into care homes, and we're actually looking at individual notes on that. So we are producing a report looking at that specific group. I think in his other question about actually with stopping doing other things, has other harm happened? It's very hard to find that information prospectively. We've got to keep an eye out to see if people do have some late presentation and then understand whether that was related to something that was done in terms of the system. Clearly, James has talked about why we're so keen and pressed to restore all the services that we had before as quickly as possible, which is not straightforward. But the reason for doing that is to prevent harm from other things apart from COVID.
Okay, so the answer is we are looking specifically at anything that went into care homes, and we're doing that on an individual case-by-case basis. The other ones, the information is not readily available, but obviously we continue to look at people who are on waiting lists anyway, in terms of if they are deteriorating or whatever.
We've done a lot of risk stratification on those patients.
Yes.
To review who's waiting and what they're doing.
Okay. Liz, was there another? Well, that was it. Was it the 2?
No. I'm afraid there's. He has actually put. So the first one was general, and he has actually put 3 questions. So that was question 1. Question 2 is on the DIPSI annual report. The SSI rates for the trust appear very poor. To ensure this is not further compounded, and with the hopefully sustained return to more normal patterns of surgery and treatment, what systems, procedures have the Trust put in place for near-patient testing for COVID-19 within surgical, cancer and imaging departments, where rapid, accurate testing is a prerequisite to the patient receiving care?
I think we'll probably take that one offline.
Okay.
I think, David, yes?
Yeah, I think there's two bits to that question. One is a question about screening on getting people to surgery, and we've got very clear guidance around that and how we're testing people, and we are putting in near patient testing. The other bit is a bit more involved, and that's about the surgical site infection rate, which we agree with, and as we discussed in the open board, the rates are high, and as you can see, all the work and effort that we are doing to reduce those. And as you said, Andy, we have to turn the dial on that. So,
yes.
So that is, so he's right. We are trying to address that.
Yeah. And indeed, it's our North Star objective, and all the processes are being put in place around that. Okay. Yeah. And finally, Liz.
And the very last one, across the board reports, much emphasis is placed upon the new operating model and virtual consultations, with mention being made that patient feedback has been fantastic. Whilst I'm sure the patient feedback has been fantastic, I would like to know how actual patient outcomes are being captured.
How patient outcomes are being captured? Surely on patient notes, aren't they? David, isn't that how patient outcomes are captured?
Yeah.
On an individual basis?
Yeah. I suppose it is the same process. It's the same process that we normally use. Yeah. It's just the consultation is done virtually. I think what David is asking is, does it put through some additional risk to patients having their appointment virtually rather than in person? And that's what we're trying hard to make sure that actually virtually, we only see the patients virtually, that actually there is no additional risk. And we're still seeing some patients in quite a proportion as we come out of COVID.
And I suppose it's a balance, isn't it? Because, we don't want to go back to where we were. On the other hand, those who need to be seen face to face will be seen. So it's that balance of not losing the gains we've made through virtual consultations, whilst actually seeing the ones that need seeing.
Yeah. I suppose some of the metrics, we pick up incidents and misdiagnosis and things like that. We've just got to keep an eye on that to make sure that isn't a problem when we change the model. So those are captured already.
Okay.
And Andy, we do let the sorry, Andy. The clinicians do. There is a process around risk stratifying and selection of which patients are in virtual clinics. As I said in the performance report, we've allocated rooms on the basis of what's needed in terms of face-to-face. So clinicians have all done reviews in their specialties. So there are cohorts or stages of patients that would naturally be diverted to the most appropriate modality.
Okay, thank you. Thanks for that. I think we've covered those questions. Okay, so we've come to the end of the agenda. Anybody want to share any reflections on this meeting, apart from we've managed to finish it in good time, which is good? Or are we all stunned into silence with it's a long meeting, actually. Okay, Neil.
Yes, look, thanks everyone. It is, Andy, you're right, it is a heavy lift when you follow a closed board meeting with an open board meeting. But I think, just as a reflection, the agenda today seems to me to have struck the right balance. We've had a good discussion about the kind of longer term strategic risks, and we've also had a good drill down into some of the actual kind of day-to-day operational performance issues. And I think that the key point I note is the assurance that I got from my fellow non-executives around the minutes and the committees that they chair. That provides me with an oversight and assurance on the committees where I don't sit, that convinces me that we're doing a good job from a governance point of view, and obviously that relies upon the cooperation, engagement, involvement and support of our executive colleagues on this board as well. So I think a successful meeting overall, and acknowledging also it's very difficult for you to chair such a meeting because you're always on throughout the many hours. So thanks to you for doing that as well, because it's a difficult job online.
Thank you. Yes, I also got good assurance that, and obviously I do attend some of them, not all of the time, from the committees, that the committee structure is working and the committees are doing their job, and then providing us at the board with assurance that they've done their job. So I think that is well done to all the committees, actually, because it makes the board meeting more straightforward. So thank you for that. Okay, now we are going to bring this formal meeting to an end. I think, Sal, we have some training at 2 o'clock, is that right?
Let me just check.
We also have the charities.
We do. So thank you for reminding me. We do now need to go into the charities one. Yeah.
And the training starts at 2:15, Andy. So we have a short break after the corporate trustee board.
Okay. So are we straight into the charities one then, Sal?
I believe so, yes.
It'll be straightforward. Oh, and is that a different recording, a different link?
I think so. I'll close this one and start a new one.
Okay, that'd be easier from a recording point of view. Okay, thank you.
Andy, I don't think I'm on this one. I'm happy to stay if you want me to, but otherwise I'll dip out.
I don't think we've David's call really.
I think that's fine.
Yeah.
Okay. Thanks very much.
All right.
Thank you.
See you in a moment. Thank you. Bye.
Bye.